This lecture is entitled Introduction to Patient-Centered Care. I'm Paris Dudonyai and I'm Professor of Social and Cognitive Pharmacy at Reading School of Pharmacy, and I'm also the Director of Pharmacy Practice. So the overall learning outcome from this lecture is for you to be able to understand patient-centered care as the need to integrate a patient's own experience of health, illness, injury or need with your therapeutic and clinical expertise that you will be developing in caring for and managing that patient. So a substantial element of your pharmacy course involves teaching you about the role that biology plays in understanding disease and its treatment. But there is more to health and disease than physical and biological processes. Now, clearly, organs of the body which are targeted by drugs and which you will learn about during your pharmacy degree are part of the physical body. But we also know that psychology and sociology play a role in understanding disease and treatment. The popular view of disease is summarized by the expression, the biomedical model. Indeed, this model underpins all of the pharmacology, the chemistry, and the formulation science that you learn about during your degree. Within this model, disease is associated with identifiable disturbances to the body and can be defined in terms of such disturbance. A cure, therefore, consists in correcting that disturbance. For example, cancer is clearly a disease caused by an uncontrolled division of abnormal cells in a part of the body. A heart attack happens when the blood supply to the heart is suddenly blocked, for example, by a blood clot. Therefore, the aim of cancer treatment is to get rid of the abnormal cells, and a heart attack is treated by getting the blood flowing again to the affected part of the heart. So, under the biomedical model, disease is defined by abnormalities in the structure and function of organs and body systems, as defined by biomedicine. According to the biomedical model, only diseases defined in this way are to be dealt with by medical intervention. Now, you will probably recognize that this has several implications. For example, if no identifiable disturbance can be seen, then the issue cannot be considered to be a medical one, can it? Think of conditions that are hard to diagnose, for example, chronic fatigue syndrome, fibromyalgia, or irritable bowel syndrome. So I want you to think about how biomedicine might deal with these conditions. Now, on the other hand, if a measurable, identifiable basis in the body is found to be the cause, under the biomedical model, the issue can be seen as a medical one which needs medical treatment of some sort. And again, this can be problematic if actually the first line management might well be something else, such as psychological treatment. Think of conditions such as anxiety and some forms of depression. Under the biomedical model, then, there is a very clear dichotomy in terms of what is or what is not a disease, based simply on biological criteria. So far, I've mentioned the biomedical model. Now, it's really important at the start of your course for me to point out what we actually mean by a model. A model is a bit like a theory. So it's an idea of how things are or how things work as a hypothesized representation. So here on the screen, for example, I've shown you the core constructs of the health belief model. But a model is not a concrete thing. It's just somebody's idea. Models, of course, exist. They can be tested in some cases to enable predictions to be made, which are then supported or refuted by study evidence, but models are not concrete. They're not real physical objects. And they don't exert any power. So there is a danger which you should recognize, of taking abstractions created for the purpose of promoting understanding and giving them unduly a concreteness. So, for example, giving a model, such as the health belief model, an entity, an existence as a causal agent, which it cannot possibly be. Now, this is quite a complex idea, and I mention it here just so that you've got some background understanding of this. And it means that we need to be careful not to concretize the biomedical model as a thing beyond an abstraction. Therefore, we cannot say that the biomedical model causes people to be treated as engines rather than as a human being. The model cannot be the causal agent. So there is a key term, reification, which is when an abstraction that we have created to help us understand reality, for example, a model, is seen as something concrete which really exists and exerts a causal influence. For example, saying the biomedical model neglects people's personal experiences. This would simply be wrong. Going back, other problems with the biomedical model have also been identified and described. For example, even if there is a disturbance somewhere in the body, the individual usually presents for treatment because they're subjectively experiencing something like pain, discomfort, or distress. That is, if they present for treatment at all. And that's because there's also a cultural and social dimension in terms of how this illness is expressed and the subsequent help that is sought. Biology alone does not give the full picture. There is no single way to describe how people cope with illness and the idea of mortality. Social, cultural, psychological factors are involved in the risk of becoming sick, how sickness is defined, and how symptoms are interpreted, and indeed people's response to those symptoms. So, to some extent, people decide to become or remain patients, as well as being defined and labelled as patients by doctors. So it's now suggested that to grapple with the complexity of people's experiences of health and sickness, there are other useful models beyond the biomedical model. It's recognised that being a patient is also a social and psychological state and not simply a biological one. Now here's an example. Research has shown that the efficacy of mood-altering drugs is due to expectations about their effect, and this is an example of the placebo effect. So what do we mean by this? What we mean is that if you have a drug that exerts, for example, an antidepressant effect, and if you tell the patient that this is an antidepressant, you can actually get the person who's taken your antidepressant to be less depressed or be more happy simply by virtue of knowing that they are taking something to treat their condition. And similarly, a part of the efficacy of the pain-reducing drug morphine is due to these sorts of expectations about its effect. So the placebo effect means that when a drug company wishes to introduce a new product, its effect must be checked against a placebo. That is, two groups of participants would be treated identically in terms of receiving the new substance, but only one group would receive the new drug. The other group would receive a chemically inert substance that would look, in appearance, exactly like the new drug that's being tested. Placebo-controlled trials often find that the group taking the placebo shows some improvement, for example in their mood, compared to taking nothing at all. Although, of course, in drug trials, you do have to think about the ethics of giving people nothing at all, depending on the type of condition that you're treating and the level of the trial. but you will learn more about this through the course of your degree. Now, for a new drug to be approved, a beneficial effect above that of the placebo, or whatever the standard treatment is at the time, would need to be demonstrated. So a key term for you to understand is placebo, which is a medicine or procedure that has a psychological effect on the patient rather than any physiological effect, or a substance that has no therapeutic effect but which is used as a control in testing new drugs. Now here's another study that illustrates the complexity of people's reaction to health and illness. Now imagine this study looked at the effectiveness of high-dose antacids for treating stomach ulcers. All of the participants were examined with an endoscope at the start and end of this 4-week study. While half received the antacid, the other half received a placebo, without knowing it, and actually without the investigators knowing who received what. So this is known as a double-blind study. At the end of the study, it was shown through doing endoscopy that the people who'd received the antacid had a clear improvement in their ulcer status. Now, you would expect this. However, there was no clear difference in terms of the symptoms experienced between the people in the two groups. Now think about this. So, some people whose ulcers had healed still had pain, and some people whose ulcers had not changed no longer reported any pain. So one way to help understand these sorts of phenomena is to have a distinction between disease and illness. So here's something for you to think about. Doctors diagnose and treat disease. These are abnormalities in the structure and function of organs and body symptoms. And patients suffer illness. So this is their experiences of malfunction in states of being and also their social function. This is put nicely in the statement. Illness is what the patient feels when they go to the doctor, and disease is what they have on the way home. So almost the labeling of their condition by the doctor. Illness can also be seen as the patient's subjective experience of physical or mental states, whether based on some underlying disease pathology or not. But illness can also be social. The experience of some illnesses is not limited to the symptoms, but includes maybe a second illness. That is, the reaction of the social environment, for example, the stigma associated with the disorder. So here, stigmatization is an additional dimension of suffering added to the illness experience. Think, for example, about mental health conditions or a diagnosis of HIV. And you'll understand then why in contemporary Britain there is a drive in terms of increasing awareness about mental health conditions. Now, parallel to this is the distinction between cure and healing. Doctors can cure disease, but that does not mean that the patient's illness is healed. Cure simply implies the absence of disease or its expulsion from the body, whereas healing refers to the improvement of the ailing body and the well-being of the ill person. Now, you might wonder how the biomedical model came about. It's acknowledged that Western medicine and biomedicine has its roots in the distinction derived from ancient Greek philosophy between reality and appearance. This tradition assumes that behind the changing and often chaotic surface of events, there is a more fundamental, permanent, universal reality, God's grand plan or scientific truth. But legitimizing a single underlying truth can foster intolerance toward alternative paradigms. So we can see so far that the biomedical model is also materialist. So it assumes that reality is basically material, that nature is physical, and we can obtain objective knowledge of it independently using our senses and the methods and instruments that we can use to observe it. The theoretical framework here is that of positivism, which is an approach to knowledge construction that's based on quantitative measurement. So events that give knowledge and meaning are measurable. And there's always a cause and effect, and if you cannot measure it, you cannot understand it. This leads to a reductionist view of sickness. The term reductionism refers to seeking an explanation of events by looking at only one level. In the case of health and illness, this is usually the biological level. Therefore, here, the body is seen as a machine, with the heart being the engine, for example, the urinary system being the plumbing, and so on, such that the body becomes a series of interconnected parts which can be mapped as an anatomical atlas. A key term for you, therefore, is reductionism, the practice of analysing and describing a complex phenomenon in terms of its simple or fundamental constituents, especially when this is said to provide a sufficient explanation. With a reductionist perspective, sickness is confined to physical bodies rather than being a social phenomenon situated in groups. Sickness is reducible to the malfunctioning of the basic material building blocks, the cells and the molecules, rather than disrupted social relations. The signs of sickness are visible under the microscope or in a test tube, rather than in the complaints and stories of the sufferer. Doctors are seen as engineers or mechanics, and they are there to fix or mend the dysfunctioning body. A reductionist perspective assumes that all diseases are due to specific identifiable agents, therefore, for example, parasites, bacteria, genes, etc. And that these agents, for example, attack the body, and that because all diseases have a specific cause, these agents can be treated through medicine. So finally, the cure is in the form of a pharmaceutical magic bullet rather than holistic healing. The solution to medical problems are therefore found in technologies such as drugs, new parts, for example, artificial hips or heart valves, or machinery, for example, a dialysis machine. This approach is linked to mind-body dualism, the idea that medicine only tends to treat the body and neglects the mind, therefore may not treat the true cause of the problem. So an alternative model to understanding health and illness is the biopsychosocial model. And this involves a study of the biology of the body together with the individual psychology and social circumstances of the patient. The biopsychosocial model rejects the neat dichotomies of the biomedical model. According to the biopsychosocial model, disease, which is simply defined in terms of biology, is not a useful way of approaching distress and well-being. It's not only that biological, psychological, and social circumstances play a role in someone's distress or well-being, but I want you to also note that the biopsychosocial model acknowledges an interdependence between these different factors. For example, changing someone's social circumstances can change his or her psychology, how they think and interpret things. And changing someone's psychology can maybe change their social interactions. Changing someone's psychological state can also change the way their brain works. For example, psychological treatments can have a positive impact on depression and brain activity. So a key term for you is the biopsychosocial perspective, which considers interdependent biological, psychological, and social factors as equally important in explaining health and illness. A biopsychosocial perspective is a form of holism. Holism is the theory that parts of a whole are in intimate interconnection such that they cannot exist independently of the whole or cannot be understood without reference to the whole. The whole then is regarded as greater than the sum of its parts. In health, holism refers to treating the whole person and considering psychological and social factors rather than just the symptoms of a disease, and is therefore implicit in a biopsychosocial perspective. The biopsychosocial perspective also allows us to focus on maintenance and promotion of health as opposed to fighting against disease. It challenges the mind-body dualism. Behavioral, social, economic, environmental factors all influence health. Health beliefs influence health. So, in considering and caring for someone using a holistic approach, we need to consider and care for the whole person, not just their disease. Therefore, patient-centered care advocates listening to the patient fully, exhibiting care and compassion, and engaging in other agreeable behaviours to improve the patient's psychological, physiological, and functional outcomes all at the same time. And patient-centered care also encourages focusing on patients and their concerns rather than merely their disease and their assessment. And practitioners are encouraged to see the illness through the patient's eyes. So seeing the illness through the patient's eyes involves listening to and respecting the patient's beliefs, understanding that patients are affected by different socioeconomic circumstances and that these impact on their knowledge, beliefs, as well as experience of health and illness, understanding that patients may want to behave in a way that's different to medical advice, involving patients in decision making, and make sure that patients are consenting to services that you provide. This is the end of the lecture, and hopefully you now understand patient-centered care in a little bit more detail. You understand that patient-centered care means that we should put the patient at the center of decisions about their healthcare, and you have an understanding of why we integrate a patient's own experience of health, illness, and injury with our own therapeutic and clinical expertise when caring for and managing them.